Swayam Prabha. Digital India. Educated India.
Today we will discuss about the diseases of the pituitary gland. Pituitary gland is a very small endocrine organ which lies in the sella and is well protected all around by a bony cage and above by the dura mater, which is the diaphragm celli. Pituitary gland is although very small, but it is also known as the master gland because it controls almost all the endocrine glands in the body except the parathyroid gland and the pancreas. So now the secretion of the pituitary hormones is under the positive and negative feedback. Whenever hormones from the other organs, their level rises, there is a suppression of the releasing a trophic hormone from the pituitary gland. There is a releasing hormone or releasing factor which are secreted by the hypothalamus, which act on the pituitary gland and causes secretion of the releasing hormones, which act on the endocrine organs and secrete some hormones. These hormones, they goes to the blood and act on the target organs. There are some receptors on the target organs. These hormones, they stimulate the second messenger hormones, which causes the actions in different tissues. As we know that pituitary gland has two parts. One is the adenohypophysis, which is also known as the interior pituitary, and the posterior pituitary is known as the neurohypophysis. Both of them develop from the different parts. The interior pituitary adenohypophysis, it develops from the branchial arc, whereas the posterior part, it is a part of the brain. Both grow and meet together and form the pituitary gland. Now, the development of the pituitary gland is under the control of some of the transcription factors. Under the influence of these transcription factors, the anterior pituitary gland differentiate into different kinds of cells and secrete different hormones. This shows the control from the hypothalamus. The plus shows the positive control, whereas the minus shows the negative control on these hormones. Interestingly, pituitary gland has portal circulations. Now, the diseases of the pituitary, they are classified mainly when there is a hyperfunctioning of the pituitary hormone or pituitary gland, or it may be the hypofunctioning. The hyperfunctioning is known as the hyperpituitarism, whereas the hypofunctioning is known as the hypopituitarism. Sometimes there is involvement of the posterior or adenohypophysis, which secretes the ACTH hormones, and it leads to the diabetes insipidus. The most common cause of hypopituitarism is adenomas. It may be of any kind of adenomas, and depending upon which hormone is secreted, the manifestation depends upon the type of the hormones. Pituitary carcinoma, they also cause hyperpituitarism, but pituitary carcinomas are extremely uncommon. Adenomas are the most common tumor of the pituitary gland. The only criteria to call something pituitary carcinoma is metastasis at a distant site. The most common causes of hypopituitarism are after the surgery. For example, someone is going surgery for the adenoma, which is hyperfunctional, and during surgery the normal part of the pituitary is also removed. So, it causes hypopituitarism after surgery. Sometime after radiations, when the pituitary gland is irradiated for adenomas, it may lead to hypopituitarism. Rarely there may be some infections or there may be some tumors from the adjacent, maybe from the bony case, maybe from the brain, which causes hypofunctioning of the pituitary gland. The pituitary gland also undergoes sometimes hyperplasia, especially during pregnancy, and after delivery, if there is excessive bleeding, there is infarction or there is less supply to the pituitary because of the shock, and it leads to the hypopituitarism, also called the Sheehan syndrome. So, these are some of the important causes of hypopituitarism. Now, pituitary adenomas are the most common tumor of the brain. They comprises about 10 to 25% of the all intracranial neoplasm. Numerous classification has been proposed from time to time, and the most common which clinician use is the non-functioning pituitary adenomas and the functioning pituitary adenomas. The non-functional pituitary adenomas are the one which do not cause any symptoms or the syndromic symptoms or because of the excess hormones, whereas the functioning pituitary adenomas, the hormone levels are high, therefore they cause symptoms, for example acromegaly, amenorrhea, galactorrhea, Cushing syndrome. This is the most common classification which is used by the clinician. But in pathology, earlier people used to have a 5-tier system of classification of the pituitary adenomas based on the clinical, which I mentioned, the functional and non-functional, based on the radiology, based on the morphology, the features of the cells, depending upon the staining of the cells with PS stain. Immunohistochemistry, we have antibodies against almost all the hormones, and one can do the immunostaining. In functional pituitary adenomas, these tumor cells, they are positive for these hormones. And any tumor which is positive for these antibodies or for the immunohistochemistry, but not causing any symptoms, that is the hormones are not released in the circulation, they are known as silent pituitary adenomas. Then based on the ultrastructure features, size of the granules, the number of the granules, the number of these mitochondria, the number of the endoplasmic reticulum, they were all used in the classification of pituitary adenomas. And depending upon the size, pituitary adenoma based on the radiology, they may be microadenomas which are less than 10 millimeter, or they may be macroadenomas which are more than 10 millimeter but less than 4 centimeter. Any pituitary adenoma which is more than 4 centimeter, we use the terminology as giant pituitary adenomas. Now, the pituitary adenomas can be classified based on the immunohistochemistry, and sometime we can do the immunogold labeling. For example, this pituitary adenoma is positive for both FSH and LH hormones. So, we do not know whether it is actually secreting FSH or LH, or it is a cross reactivity of one hormone with the others, which can happen during the staining in the immunohistochemistry. In these instances, one can use the immunogold labeling. These are the gold particles which are tagged with these hormones, one of these hormone, and different size of gold particle can be used. And depending upon this is a very specific technique. Here one can see that these gold particles, they are deposited on these neurosecretory granules. These are of 5 nanoparticles. One can use the 10 nanometer particles or the other size of particles. So, this technique earlier people used in the classification of pituitary adenoma, but the latest 2017 classification, there 2 factors are taken into consideration. One is the which hormone is produced by this tumor and the transcription factors. In the development of pituitary gland, the cells, there are some transcription factors which are playing very important role, and depending upon the which transcription factor is involved in the development of these cells, one can classify these pituitary adenomas based on these hormonal staining, their secretion in the blood, and these transcription factors. And depending upon the intensity of the staining or based on the ultrastructural features, these pituitary adenomas can also be classified into densely granulated or sparsely granulated. The exact pathogenesis of the pituitary adenoma is not known, but there is one hypothesis that normal pituitary gland, which is under the control of some of these oncogenes and the suppressor gene, if there is inactivation of tumor suppressor gene, the tumor cell, these cells, they enter into the cell cycles and it leads to hyperplasia. Initially there is formation of small microadenoma, which I mentioned is the less than 10 millimeter, or under the influence of some of the epigenetic events, or there may be some additional changes, it undergoes in the formation of larger size or macroadenomas, and very rarely it disseminate and causes drop metastasis or may go to the other places in the body. Now, there are large number of genetic syndromes where pituitary adenomas may be part of those syndromes. For example, MEN syndrome, MEN4 syndrome, Carnage complex. There are many other conditions where there some pituitary adenoma may be the part of those syndromes. In type 1 MEN and type 4 MEN, in type 1 there is a tumor suppressor gene which is inactivated on chromosome 11, whereas in the type 4 MEN syndrome there mutation of the CDK N1B. Now, both syndrome they causes the pituitary adenomas, parathyroid hyperplasia or adenomas, or the tumor of the endocrine pancreas. The only difference between the two is in MEN4, although the manifestation are same, but the majority of these patients they manifest after the age of 50, whereas in the MEN1 syndrome they present or they manifest in the early age. Now, one of the most important challenge for the pathologist is whether this is a normal pituitary gland or it is a adenoma. As we know that pituitary adenomas are sometimes very small, they are microadenomas, and the surgeon operates through the transnasal approach. So, the surgeon don't know whether he has removed the adenomas or whether he has removed the normal pituitary gland. So, when this specimen comes to the pathologist, many times if the person is not aware to the morphology or to the differences between the normal pituitary gland and adenoma, there can be confusion. Normal pituitary gland, the cells are arranged in trabecular fashion. If you do the reticulin stain, the sinusoidal reticulin is positive, and these cells they are of different types. They are polymorphic because the pituitary gland has many types of cells, whereas in the adenomas the cells are arranged in compact fashion. If you do they are monomorphic because pituitary adenoma is a clonal disease, it arises from the one cell. So, most of the times it is one type of pituitary adenoma. It is very rare that one gets the mixed type of pituitary adenoma where two types of hormones or two types of cells are present. These adenomas they are reticulin poor. The reticulin stain which can be seen around the larger group of cells, not in the sinusoids or in a trabecular fashion like the normal pituitary gland. So, this is very important to differentiate between the normal pituitary gland and adenoma, and reticulin is the one stain which is very helpful in these situations. One can also do immunohistochemistry. In a pituitary adenoma, one finds only one kind of hormonal staining, whereas in the normal pituitary gland, one can see all kinds of cells or different types of staining. The most common adenoma of the pituitary gland is the prolactinomas. They are most common types of hyperfunctioning pituitary adenomas, and they causes increased prolactin levels. There are other causes, as I mentioned here, where the prolactin levels are raised during pregnancy, during estrogen therapy, during renal failure, hypothyroidism, hypothalamic lesions, or some people when they are on the drugs, there may be some mass in the skull which causes compression of the pituitary stalk and causes the raised prolactin levels. So, one has to differentiate all those causes or the secondary causes where prolactin levels are raised. Prolactin level, when they are very high, they causes amenorrhea or galactorias in females. In males, they causes the loss of libido and infertility. Most of the prolactinomas, they are diagnosed during the reproductive age or in postmenopausal women. Because the symptoms are subtle, so many times the people, they don't complain or they don't tell their symptom to the doctors. Therefore, the diagnosis may be delayed many times. And one has to remember that prolactinomas, they are medically treatable also. There are some drugs which can be used against these tumors if surgery is not possible. This is one case of prolactinomas. This is a large tumor in the cellular supracellular region. This is the microscopy showing the sheets of these cells with the scant or moderate amount of cytoplasm, and these cells, they are immunopositive for prolactin, which is strongly positive. So, this was a case of prolactinoma. One should also remember that prolactinoma is one of the tumor which produces amyloid material. There are many tumors in the body which sometimes produce amyloid, and prolactinoma is one of them. The other very important tumor is the medullary carcinoma of thyroid or the insulinomas or the pancreas, and this amyloid is positive for those Congo red stain. It can show the green birefringence on polarizing microscopy. The other common pituitary adenoma is the growth hormone secreting pituitary adenomas. They causes the abnormal glucose tolerance, diabetes mellitus, generalized muscle weakness, hypertension, arthritis, osteoporosis, and congestive heart failure. They are usually symptomatic, and when this adenoma, which occurs before the fusion of the cartilage, it causes the gigantism. When it occurs after the fusion of the cartilage, it causes acromegalies. These people, they are very tall, they have coarse feature, thick tongue, broad nose, and very thick hands. These are some of the very characteristic feature of the growth hormone secreting pituitary adenomas. And this shows the microscopy. These are the tumor cells which have a very eosinophilic cytoplasm, abundant cytoplasm, and these cells, they are positive for growth hormone. Now, depending upon whether it is the sparsely granular or the densely granular, immunohistochemistry can tell whether in the sparsely granular there are few cells which are positive for growth hormone, whereas in the densely granular, the cells, they are diffusely positive for growth hormone. And if you do the electron microscopy, one finds a lot of these neurosecretory granules which are dense core granules, small granules. In comparison to the densely granulated growth hormone secreting adenomas, the sparsely cellular pituitary growth hormone secreting pituitary adenoma, besides that GH immunopositivity shows focal positivity or few cell positivity, if you do the cytokeratin staining, it causes very characteristic paranuclear dot like positivity. and this correspond to the, if you do the ultrastructure examination, this correspond to the fibrous body, which is nothing but the collection of the sum of the intermediate filament and few neurosecretory granules. So, one can differentiate between the sparsely granulated and the densely granulated pituitary adenoma based on the immunohistochemistry and ultrastructural features. The other pituitary adenoma which is common is the ACTH secreting pituitary adenomas. They causes the Cushing disease. They are usually microadenomas because they are functional. So, they are detected very early when the size is less than 10 millimeter. And interestingly, many times because the symptoms are very severe, these pituitary adenomas which are very small, they are not picked up by the routine radiology, CT scan or MRI scan. And many of these patients, they undergo adrenalectomy for these symptoms, and after some time one finds the increase in the size of these pituitary adenomas. They are very characteristic features: facial plethora, acne, typical moon faces, buffalo, hum, more number of hairs on the face, temporal hair recessions. These are very characteristic of the Cushing disease or Cushing syndrome. And they have central obesity, there is wasting of the muscle, maybe muscle weakness, these very prominent stria. All these are very characteristic feature of ACTH secreting pituitary adenoma. One can demonstrate these cells which are immunopositive for the ACTH hormone strongly, or maybe focally positive if they are sparsely granulated. The other pituitary adenoma which is common is the gonadotroph. Earlier all those were classified under the non-functional pituitary adenoma because most of them they occurs in the middle age or old age. The size of these adenomas is very large because they hardly produce symptoms or their symptoms are very subtle, and the most common are the diminished libido, impotence in male, menstrual disturbances in female, or sometimes galactorrhea, because the symptoms are very subtle, or sometimes people do not tell the symptoms. People are shy to tell their symptom, and that may be the reason that these pituitary adenomas, they are diagnosed late and they are larger in size, and most of them they present with the some of the compression symptoms or visual symptoms. But they are very characteristic morphology. They have these perivascular pseudo rosette like the ependymomas, maybe some rosette like structures, or they may show some solid areas. And if you do the hormonal staining for the FSH or luteinizing hormones, they are positive for these hormones. Thyrotroph pituitary adenomas are very rare as compared to the other adenomas. They comprises about less than 2% of all pituitary adenomas, and they may be associated with the MEN syndrome, and they causes the hyperthyroidism. This hyperthyroidism differs from the hyperthyroidism which is because of the thyroid gland, because here beside the T3, T4, the TSH levels are also very high, whereas in the any cause of hyperthyroidism which is because of the dysfunctions of the thyroid gland, the TSH levels are very low, whereas in the hyperthyroidism which is of the pituitary origin, the TSH levels are also high. From the morphology one can suspect, because these thyrotroph pituitary adenomas, they have very characteristic spindle shape appearance, lot of fibrosis, sometimes calcification, and these are the some of the features based on which one can suspect, and one can do the immunohistochemistry for TSH hormone, and these adenomas are positive for TSH. Null cell adenomas are the one which do not produce any hormones, or if they produce some hormone which are not functional. There may be something wrong in the aggregation or in the secretion of these hormones. They occur in the older age, and most of them present with the compression symptoms, visual symptoms, intracranial hypertensions, headache, vomiting, They are very large in size and they increase in size, and they may be invasive, which may invade the supracellular regions, cavernous sinus, go to the posterior fossa. Many times they are giant pituitary adenomas. We also carried out some study to differentiate between the functional and non-functional pituitary adenoma in India, and we found that functional pituitary adenomas, they are more common between the 20 to 40 years of age, both in male as well as female, whereas the non-functional pituitary adenomas, they are most common after the age of 40. The other tumor which occur in the pituitary gland are craniopharyngioma. There is one peculiar type of tumor in the sella which is pituitary adenoma with some neuronal component or some neurons. There is some spindle cell oncocytoma, pituitaricytoma, granular cell tumor. Rarely there can be germ cell tumor in the sella, paraganglioma or alveolar soft part sarcomas. Most of them are very rare. Some of them, for example, spindle cell oncocytoma, pituitaricytoma, they are supposed to arise from the posterior pituitary gland or the neurohypophysis. One tumor which is sometime one gets the pituitary adenomas, symptoms also they are symptomatic, and beside the adenoma component there are some large neurons. Many people earlier used to think that these are the choristomas, then some thought these are the gangliocytomas, but now it has been found that these are nothing but the pituitary adenomas, and the cells which are neuronal cells, which is metaplasia. If you culture these pituitary adenoma cells in the laboratory, after some passages, some of these adenoma cells, they undergo neuronal metaplasia. So now it has been found that these are the nothing but the pituitary adenoma with the neuronal metaplasia. Rarely one gets the germ cell tumor, and classically the germinomas, which are nothing but like the seminomas in the testes or some tumors, germ cell tumor in the ovary. They are large cells with a lot of lymphocytes, sometimes granuloma formation, and many times if the small biopsy is taken, one may get only the lymphocytic component or the granulomatous component, and they are misdiagnosed. Like the other germ cell tumor, they are positive for CD117, the placental PLAP or the OCT4 or NSC. Craniopharyngiomas, they are low grade tumor, they occur in the cellular and supracellular regions, younger age, and many of them they present with the raised intracranial tensions, headache, visual disturbances, sometimes obesity because they affect the satiety center, hunger centers, and if they compress on the posterior pituitary gland or the neurohypophysis, they may cause the diabetes insipidus. The craniopharyngioma microscopically, they are classified in two groups, adenomatous and the papillary. Both have different molecular genesis. Adenomatous, they show the beta catenin mutations, whereas the papillary craniopharyngioma, they show the VRAF B600 E mutations, which are like the mutation which are seen in the melanoma. Papillary craniopharyngioma, they usually are they are located in the third ventricle and they occur in the young children. The recurrences are very common because their complete removal is not possible. Now, there were some other diseases of the pituitary gland. For example, the lymphocytic hypophysitis. It is a peculiar type of inflammation in the pituitary gland which occurs in the ladies, especially after delivery or during pregnancy. And these patients, they present with tumor-like presentation in the pituitary gland, and there is a lot of lymphocytic infiltration in the pituitary gland. It is some kind of autoimmune disease, and many of them they regress themselves or with the immunosuppression. There can be some pyogenic infections or abscess formation in the pituitary gland. The other most common or the interesting group is the granulomatous hypophysitis. The pituitary gland, although is very small, but is one which can be affected by tuberculosis, sarcoidosis or fungal infection. Sometimes there is no reason for the granulomatous inflammation, but these patients, especially in female, they present with granulomatous reaction or the tumor like presentation in the or space occupying lesion in the pituitary gland, and in the microscopy one finds a lot of these granulomas with the giant cell reactions. The etiology is not known, but probably these are all autoimmune diseases of the pituitary glands. So, these are some of the common as well as the rare diseases of the pituitary glands. Now, any disease which affect the surrounding bony cage, meninges, dura mater, can also affect the pituitary gland. The metastasis in the pituitary gland is rare, but sometimes it can happen, especially from the lungs. So, pituitary gland can also be the site of metastasis. Sometimes the involvement of the bony cage sella by the multiple myeloma and may present as the pituitary tumor, and sometimes they are misdiagnosed as the some of those pituitary adenomas. So, one has to be careful before interpreting the pathology of pituitary, that it is not something which is coming from the surrounding structures before we call it as the primary pituitary disease. Thank you.